myxomatosis, and everyone knows about them. Myxomatosis change is just like the nasal discharge, very weak, thick, melting, just like here. This is irreversible histological change, and if I tell to owner about this is pathological things, histological things, and they can understand, oh, I cannot cure with medication. Oh, medication is only about management, not a treatment. So this is Google photo, and when I see these photos, melted, these leaflets are closed, but here are some defects, and so this will make the regurgitations here, and the chorda ruptured. So I was very shocked. This is very sad pathophysiology. We cannot cure with medication. And here, normal, MMVD. You can compare now. ACVIM stage divided 4 stages. Stage A is not the disease. B, these are mild and moderate disease. B1, they don't need drugs. They just need annual check for echocardiogram. And B2, some patients need medication. And if some patients have been taking medications for a month or years, and then the patient came hospital because of pulmonary edema, stage C, what does that mean? Very big change happened in their leaflets, right? So from stage D, we think heart failure, and it takes months to years from B2 to stage C, but if some patient came stage C, the stage can run very fast to D. And this is progressive disease. It can take months to years, but some patients, very acute, stage D, chorda ruptured. Chorda ruptured. If some patients chorda ruptured, the patient will go to direct to D. So, what makes mitral regurgitation? Until now, we found how much MR and the figures of the heart condition, I mean LA, AO, LVIDDN, something else, but now we can find the detailed reason of MR. By using transesophageal echocardiogram, like this. This is the proof, and we can look down the leaflets from here. The traditional transthoracic echocardiogram prove here and here. Of course, the patient is needed sedation, but not very deep anesthesia, just the sedation. And we have 2 proofs. The smaller one is smaller than my finger, so under 2 kilograms we can do TEE. These are TEE videos, and here LA, here are LA, and here LV, and here aorta, and blood come from here to here and go out here. This leaflet looks thin and can close totally. And here by color, no regurgitation. Remember, this is normal, and if the leaflet is prolapsed, like here. This part go to LA. This is prolapsed, and you can see much MR. And if the leaflet fly to the LA, like here, this leaflet is flail. Maybe corda was ruptured and made a huge MR here. And now I found something new condition called tethering. Tethering is in human medication. There are tethering patients, but we couldn't find this by TTE, thoracic echocardiogram. We couldn't find this, but by TEE, we can find this. Tethering means pulling the leaflets continuously, so these leaflets cannot be closed, open continuously, and that makes MR. See here, anterior flail, posterior cannot be closed. Just this is normal, this is flail or prolapse, but this is just tethering, and it makes huge error. So TTE by TTE, we can see many numerical things, figures, and we decide to how much drugs, what drugs, how much dose, how many times, we decide that. But by TEE, what is the main cause of MR? What makes severe MR? Is it prolapse, flare, tethering, or defect, or clipped? We can find. So what is TEER? You came here because you're wanting to know about TEER and V-Clamp surgery. V-Clamp is the product name I use for TEER, and I call this surgery turn back the clock of heart without stop heart beating. Without stop heart beating is important. Open heart surgery, they make heart stop. Of course, I think the open heart surgery and repair directly is gold standard. But in human case and dog patient, if some patient have high risk in surgery, they cannot be received open heart surgery. And among surgical technique, resection, the problem, and suturing, and annuloplasty, and artificial corda, and there is edge-to-edge repair. Suturing here, the center of the leaflets, and make the big hole 2 small holes. In human medicine, they use this technique by intervention. Transcatheter, edge-to-edge repair, use mitral clip, and they access to the femoral vein, goes to right atrium, and puncture the arterial septum, and then goes to left atrium, and then go down to left ventricle and open the clip like umbrella, and they clip the leaflets. They use this, and they do this in only high-risk patients. In Korea, over 80, the oldest the oldest patient was 92 years old, and the success rate is over 95%. Very amazing. They have been doing this for over 10 years. But in dogs, we cannot do this because dog patient is small and you already saw the leaflet moving, prolapse and flare. Do you think this clip, this direction can catch the leaflet? No. So we should go from the apex like this. Heart is beating, and here, apex, I insert a guide wire, and along the guide wire, I insert a bushes, 14 French, just like 10 size, and go to left atrium, open the clamps, and then clamp these leaflets. If everything is okay, we release the device, and then a new tissue is covered here. I think the two things are amazing in this method. First is not stop. We don't make the heart stop. We do this on beating heart. That is important. And the second is more important. Here will be covered with healthy fibrous tissue. And this means we can retain the safety zone. No myxomatosis change here, the center of the leaflets. So we can retain safety zone, and if some patients progress the MMVD after V-Clamp surgery, but here no myxomatosis change. That is important. Right after surgery and 2 years after surgery, of course this is not my patient, but here you can see very strong tissue. And this is my patient. I checked C-arm after surgery. You can see very stable clamps here. You can imagine, oh, there is mitral leaflets and captured, and here is left ventricle. And this moving is so stable. So you think V-Clamp will be easy? Looks easy? Many people thought it is easy because we can understand what's going on. Everyone can know what's going on the monitor. But very difficult because we are doing this in beating heart and the leaflet is flying. So capturing the flying leaflets without tearing is very difficult and very heavy to surgeon, because if something happened, if we failed, the only result is death. Fail means death. So the surgeon's shoulder very heavy, so stressful. We need 3 people, 3 surgeons. Actually, this lady is ultrasound doctor, but she is my eyes. Because I should do surgery on this monitor, not a real heart. I should see the monitor and I should manage my device with monitor. I cannot see inside the heart. So she's my eye and he is my left hand. I just right hand. So I think we are 3 head, 1 body. Do you know this? Kerberos, the guardians of Hades. So we have 3 brains, but we should think at the same time, same thing. he, the surgeon, and I should breathe at the same time. So, if you want to make success with V-Clamp, first, you need amazing teamwork of surgery team, including ultrasound doctor and surgeons who have many experience in thoracic surgery, and 24-hour intensive care team, and great anesthesiologist and internist. I mean, success in surgery doesn't mean success. Yeah. My success is the patient is alive and live happily very long time. So I will explain about this surgery step by step. Before the V-Clamp surgery, we need TE exam first, at least 24 hours before, because we need to think time. We can do V-Clamp surgery really if we do surgery in contraindication patient, the patient will die. So we should think at least 5 times. And then this patient is so standard patient, not so difficult, because leaflets are, you can see the prolapse here, and in 3D, no defect, no clipped, and 5 kilograms, only stage C, 11 years old, Schnauzer's patient, very good patient. But we can see huge MR, like this, and we measure the AP diameter and the length of leaflets. If the length is very short, under 5.5 millimeters, we cannot do surgery, very risk. And I open left 6 or 7 or 8. I decide by X-ray the heart apex, and then you can see here pericardium. I excise the pericardium and suture here like this, and I can see the heart, and with cotton tip I should decide what point I should puncture. And then here I already did purse string suture and insert blue sheets. You already saw in the animation. This is guide wire, and during inserting catheter, you can see not much bleeding. Actually, no bleeding here. And doing surgery with monitor. I manage this device on here, and on 3D view, I manage the rotation. On 2D, I manage here, forward, back, up, down. And the guy manages the first clamp. He can make the length short, long. He can open the clamp. He can close the clamp. He can do a hard close and release. I just move. He just open and close. So in the monitor, here, guide wire inserted, and then I already insert a catheter along the guide wire, and then this is, we called mesh ball. We use this not to, we use this to protect chorda, and along this, our catheter go to this. here like this, and then remove the mesh ball and insert the device clamp. The first clamp is open, and second clamp is opened, and then here leaflets are moving between clamps, and rotation perpendicular to the leaflets, and then everything is okay. Close, hard close, like this. Before hard close and after hard close, you can see MR decreased. At this point, we should measure many things about the pressure gradient in mitral valve, how much length we capture, is it enough, and how is the angle. So we need 2 or 3 minutes, and I should hold the device not to move. That is very difficult to me because I cannot do anything, just hold it. Don't push. If someone push me, patient will die. Yeah. If everything is okay, we can release. And look at his hand. I hold not to move, and he is turning the button to release. Because we are not same person, he rotates by this direction, and I should hold the power opposite. But I don't know at first how much his power, so I shake my hands. And after that, we remove this catheter, and he is suturing. See? Because we use heparin before the surgery, some bleedings, and here, sub-Q or muscles, but there is no bleeding at the access point. And we check the bleeding here. Here is the catheter site. It's okay. And how long does it take? We need a arterial pressure line, and it would take some minutes. And preoperative TEE, about 10 minutes, and from thoracotomy to closure, about 1 hour, and catheter in heart itself, 10 to 15 minutes. So this is post-op. Here you can see the clamp. And after clamping during the surgery, what will happen in monitor? MR will be decreased, so cardiac output will be increased, so the blood pressure will be increased about 10 to 20, and the heart rate will be decreased about 10 to 20. Yeah. And before clamping, we use the drugs like dobutamine or norepinephrine to manage the blood pressure, but after clamping, we don't use that. We don't need to use that because the blood pressure will be increased. So this patient before the surgery, 2 days after, 2 weeks after, 2 months after, and then 4 months after, you can see heart size decreased. I quit all drugs, but I used chemo for 4 months after surgery. But July 12th, last week, I quit all drugs. And Post-op echo, emergent heart evaluated, LAD, normal, LAAO, normal. And finally, 3 months after, no MR. Why? I already told you about the fiber tissue. If some fiber tissue covered there, MR decreased more. So this is about recovery. The operate surgery day and day 1, client visit. This is my first patient last year. Day 2, this dog went home. And day 6, can take a walk. And after 3 months, no MR at all. Three months after surgery, I promised to the owner, okay, let's meet 6 months later. I'm very happy. This dog's mother died because of MMVD. So the owner decided to do surgery, even though I don't have real experience. This patient is my first experience. And I will tell you about very difficult case, stage D. It's just like a red hot chili pepper in Korea. Pulmonary edema, 9 times hospitalization during 2 years. Small dog, 2.8 kilogram, old dog, 13 years old, and stage D, and the dog has Cushing's and pulmonary hypertension and protein losing enteropathy. And this doctor is her internist. Very long history. Pulmonary edema has been occurred 9 times, and from beginning, 15 months, 10 months, 8 months, 3 months, 1 month, 6 weeks, 2 weeks, 2 weeks, 10 days. So the owner and the internist decided to do something at last. The final prescription here, Furo injection, Torse, and Spiro, Silde, and for tossing, Triostain, and for back pain, gabapentin, so many drugs. Before the surgery, and I find, anterior is flat, posterior is tethering. And here, there are some defects, so the surgery will be very difficult. And here, the tethering angle, it was the risk because I insert the clamp here. I thought I could tear the posterior or I could rupture the chorda. So you can see in the video. This patient lost her weight 1.2 kilogram over 6 months. Here, very big atrium. Of course, you can see this video in YouTube. But during the surgery, tethering was disappeared. Why? I think we use diuretics aggressively before the surgery, and that makes the heart get smaller, and small heart can close the leaflet. That is the secret of tethering. If you use diuretics well, the patient will be alive for a long time. So before the surgery, after surgery, decreased MR, and we were worried about her recovery because very old patient, pulmonary hypertension and Cushing's, but quick recovery. 6 hours after surgery, next day, she can walk, she can eat, and third day, she went home. But this left atrium, the size, will not be changed because it has became very big for 2 years. So the size will be changing, but the pressure is low, not high. Actually, no pulmonary edema after surgery. And she gained weight 600 grams. And what is most important prognostic factor in short-term recovery? That is mental. Recovery of mental status is very important. If some patient couldn't recover mental status, the patient will be die, I think. And then vital sign, pressure, heart rate, breathing, body temperature, and then ECG. ECG looks weird after surgery, at least 24 hours, but it's okay. If the blood pressure is normal, the ECG, VPC, it's okay. See, here, these patients, right after surgery, still sleeping with tracheal tube. But the owners are staring the dog, sleeping dog, still sleeping dog, and suddenly the doctor said to the owner, with a smile, let's finish this time, because this dog head up, looking around. And next day, in the morning, she said she is hungry. And the most important thing, patient selection. You should make inclusion by only TEE. I mean the physical things about the leaflets and the heart, AP diameter and leaflet length, leaflet status, is it intact or does it have defect or cleft? If some patients have cleft, that doesn't mean impossible, but the cleft location and the direction is important. And no other severe disease, patient age, patient size, weight. I don't know about these things because patient size, my smallest size dog was only 2 kilograms. The more important thing is heart size. If some patients are 5 kilograms but the heart is not big or heart is short, the LV is short, it means surgery will be difficult. So I think inclusion criteria would be physical score, functional score, the heart function, and biological score. Physical score is we can decide by TEE, and functional score we can decide by TTE, LV muscle contractility, and the biological score, any other disease, just like chronic kidney disease. If some patient have severe chronic kidney disease, we don't do V-Clamp surgery. But moderate, I think I can try, because the patient would be go worsen because of the furrow or torsion. And pulmonary hypertension, hormone disease, we can do. Not severe if the patient's disease is not severe. And success, surgery success, short-term recovery, long-term recovery, all is important. So in surgery, you should choose safety rather than perfect score. We don't try to decrease MR very much. I just want to make the MR decreased compared before. And contraindications, do not perform surgery that should not be performed. Very important. The learning curve, almost thing is patient selection. And this patient, here, anterior leaflet is too thick, over 5 millimeters. What does that mean? I didn't know, but I failed. Even though here, no defect, no clipped, this leaflet looks good, but I failed because these are the ghosts. Cystic nodule, the pathophysiology, I think that is just like the nasal discharge. And when I captured that and released the clamp, it disappeared. This patient looks very good here, but it's weird here. This angle, every patient is okay here, but this patient is weird here. Papillary muscle, it means heart axis is rotated very much, and I cannot see both leaflet at once. I should check both leaflet between the clamp, but I couldn't, so I failed. And this patient, looks very good here, and the owner wanted the surgery very much, but in 3D, this is the worst leaflet. You can see here, how many pieces? 4 to 5 pieces. Yes, very sad leaflet. We cannot do anything with clamp. Just open heart surgery, but the doctors, open heart surgery doctors, refused because the dog has gallbladder problem. And here. Oh. Okay. The direction here, clipped like this, very risky. Just like can cover. Tuna can cover. When you open the tuna can, imagine that. If I grab here and leaflet moving, this part will be teared along the AP. This patient has clipped here, so we cannot do surgery because zone 2, the center of the leaflet, has clipped. So 9-year-old only stage B2 but very sad leaflet. 14-year-old stage C has clipped here but the direction is okay. We can do surgery. This patient. You can hear the cough sound. Very alive dog, but she couldn't move at all because of the cough. There was a clipped, and I managed the rotation. After clamping, and this patient is 14 years old, very old dog, but 4 hours after surgery, she started to barking. She wants to go home. And next day, the second day, go home. Before surgery, after surgery, I did surgery at January this year, and that's her. She can run. I think not enough time today, so these are the sisters who received the V-Clamp surgery, 2 dogs, and they gained weight so much. They ate much. They used their muscles very well. So these are all muscles, very bad dogs. So what I want to say is, why do they think cancer surgery should be done quickly, but heart surgery should be delayed as long as possible? For every surgery, there is an appropriate time to do surgery. The same goes on for heart surgery. And now we can know the way to turn back the heart clot without stopping the heart. Please, there is no one. This dog is playing with the toy before surgery, after surgery. Okay, thank you for listening.
Thank you, Dr. Amy Youp, for the insightful session. So now we are open for some Q&A. Doctors, if you have any questions, please ask Dr. Amy Youp.
Good morning, Doctor. When you use the cotton bud to feel for the transapical insertion of the catheter, actually what are you feeling?
You mean what am I feeling?
To determine the point of insertion.
Determine the access point.
It's okay.
I can see in the monitor if I push the apex with cotton tip. In the monitor, I can see where is it, and I should go directly to the leaflet so I can choose the best way, but it is the most important thing. Access well goes to success, access bad. You mean, it doesn't mean the fail, but it means very hard surgery. Yeah.
Any more questions from the floor?
What do you really feel when you put it in? How do you know?
Hello, yeah. How do you know you already catch the leaflet? What's the feeling when you put the tear in? Is the feeling or like just from the ultrasound you can see it?
Just to, of course, I can feel the leaflets touch the clamp. It's very weird, and I feel very risky. So I should manage my mental. But if I cannot feel the leaflets, it means something happened, something really bad things happen. I can feel the leaflet moving, and after the clapping, I cannot feel because I am grabbing the leaflets. I can see only in monitor, and I should hold that without moving. But heart is moving, so I should move a little bit, yeah, with heart rhythm. Yeah, it's difficult.